Before we get started, let me read the emergency evacuation procedures. In the event of an emergency evacuation, an alarm will sound. Everyone should exit the building by way of the nearest stairwell in a safe and effective manner. If the nearest stairwell is blocked by smoke, use the other stairwell. Do not use the elevator. Once you have reached the main floor, follow the exit signs to exit the building and quickly proceed away from the building. Please be mindful of others evacuating and of emergency vehicles.
Okay, at this time, is there any public input on items on the agenda? Seeing none, we'll move on to approval of the January 19th and April 19th, 2016 minutes. Since there is no quorum to approve those, we'll put those on the calendar for the next meeting. And we'll move to revenues and expenditures. And Jenny, I'll let you handle that.
Thank you, sir. In your packet, you have our employee summary report, which has our member count, and then it breaks it down by our subscriber types as well. You can see for the month of April, we had 1,735 total employees on our insurance plan, with a count of 3,728 members, and that is down from the start of our fiscal year back in July. We have about 111 less employees, with 166 less total members, which is not necessarily a bad thing, because the fewer people you have, typically you would hope that you would have less claims, and we are starting to see that our claims are starting to kind of even out. We'll get to that here in a little bit. So some of the reasons that we've heard are employees, whether they've terminated, they've left, or they've gone on their spouse's coverage, those types of things are the reasons for that reduction in numbers. The next page, you'll notice, is our revenue and expenditures report that we typically do, but it does look a little different. I met with Dina Finley, our new accounting manager, and she and I got together on this and worked to come up with a little bit better format, and she has a little bit better Excel skills than I did, so she was able to format this to where it looks a little bit better for you. So the first page of the report will be from July to December of 2015, so the first half of the fiscal year. And that time frame was when we were with Humana, before we had made the changes to the plan. And then on the second page of the report, it carries from January to, it will go through June. Of course, right now it just goes through the end of April. And this is with Allegiance, and you can see that we have the revenues on the top part of the report, and the expenditures are on the bottom part of the report. And the net position row has been added so that you can see the difference each month. So if you look at this for this short time period, you can kind of see that we've been in the positive each of the 4 months, some more than others, but for over the course of each of the 4 months so far this calendar year. Overall for the fiscal year, we are still in the negative a little bit there, but I think we're moving in the right direction, and I think you can see that if you look at these 4 months in this year. I will say that the way we are pulling these numbers, and I'm going to ask Dina, Mike, if it's okay for us to recognize her to come and explain kind of our method and approach behind this, but these numbers are being pulled from our invoices that we receive from the vendors, in addition to the payroll deductions that we're taking from the employees. I know that there had been a lot of confusion, I think, in the past about what the website says and what the accounting site says, so I'm going to let Dina kind of explain that.
And that difference is the revenues are calculated when the payroll is processed. So we'll take the deductions from the employees' paychecks, which will be a pay period that you're paid within the month of April. And the invoice is typically the last invoice that comes in the month is going to be dated for April, May the 1st. And so when they post that in accounting, since the transaction date falls within May, we take this data directly from the invoices for the periods that are covered. So any claims that are paid in the month of April will be shown on this spreadsheet versus if you look on the website to when the transactions are posted, when they're paid through accounting, the transaction will post which might be in the prior month or the previous month based on when the invoice gets processed and the check gets paid. So that way we have a clear picture of revenues within the month that are generated for, say, April, and invoices that are for the services or claims paid within that month, so that we're looking at a clear picture of the whole month. Any questions?
And say again, Dina, if you mind, why those two wouldn't necessarily, why they don't match up?
It could be mail, snail mail, it could be email. It depends on when the invoice from Allegiance gets sent to here at us in the county that goes through HR for coding purposes, approval purposes, then makes it into accounting finance department to when we actually generate the check to pay the bill.
So it's a lag time?
Yes.
Okay.
Good.
Yep. Any other questions? And I will say that I want to commend this committee because it certainly had to make some hard decisions that took effect in January. And then if you start to look at what the numbers have done since January, you can see that the issue we had with the deficits has corrected itself, and we're on our way to a positive balance in the fund itself without having to deplete that on a monthly basis and an annual basis. So really nice work by this committee to take that problem head on and get it corrected. Okay, anything else, Jenny? All right, the next item is benefits update and presentation from CBIZ, and Cole is here. Cole, thank you for being here. We've got a lot of information here. It's all good information to cover and certainly information we need as well as the commission. So
Okay.
go right ahead and
Perfect.
jump in.
How do you want to do the slides? Do you want to, I don't think that's going to work. Since it's just in PDF. Okay. Okay, that'll work. All right, perfect. Well, we're going to hit on a range of topics. We're going to go through just an update of, again, why we're here and what we projected to start off with, and then we'll go with where we're at year to date and then some of the other topics that have come up over the last 6 months. So we'll just do an overall recap and then make some recommendations because before you know it, 2017 is going to be here. We're going to have a pretty quick timeline, so then we won't come into some of the issues that we came against last year that we'll need to address, but we need to already start looking at 2017 and what we're going to recommend and how we're going to pass that through so that we're on top of things. So let's go to the next slide, Jody. So Plan 2 update. As you all know, we had to add that second plan option to satisfy the state's requirement for the school board or for the Board of Education. The enrollment period for that has closed. It is going to be effective June 1st. So out of the 3,700 members or 1,700 employees that you have roughly on the plan, you had 23 people move to the Plan 2. So we satisfied the state's requirements, but as we anticipated, we had a very, very, very small enrollment of roughly 1.5% of your population. So of that 18 active employees, 3 retirees, 2 from the general county, 4 from the sheriff's office, 12 from the Board of Education, and then the 5 retirees. I said 3, but it was 5. So it's pretty much about what we expected. There really isn't any reason to move to this plan, but sometimes when people see a lower deductible, they just jump over it anyway. So all the ID cards were mailed last week. So everyone should have their ID cards by the end of this week that made the switch into Plan 2. If you did not make a switch into Plan 2, there would be no new ID cards and everything should be good. And we've sent this information on to the state. We've met the mandate that they required, and we are good for them. Before we get too much into the next part, The state, I've been in close contact with them as well. We're going to be in constant conversations with them as we go through the recommendation process for 2017. They are not finalized for 2017, and I anticipate they're going to make some plan changes. As you see through our presentation, I don't think we'll have any issues at all with it, but we'll obviously still keep in contact with the state as they go through it. They are not the most accommodating folks if you've ever had to deal with them. So while we would like to be part of their conversation, they would rather us not be part of their conversation. So let's go to the next slide. We're going to do the carrier recap. So this just gets into where we were last year, and this is just information directly from the PowerPoint presentation that we had from our July HR committee meeting. So I put in a little bit different of a format, so it's more consolidated instead of going through another basically hour and some odd minute presentation. We're just going through the expenses here as to why we made the change on the carriers. Humana, there is a negative expense for them to administer the runout administration. We're anticipating anywhere from $175,000 to, I want to say, $265,000, $270,000 in expenditures for this. The reason why it's a variable expense whenever we're going through this process is they take the average of your last 3 months in claims, and it's a percentage of that is what the overall cost is for runout administration. When we gave the presentation in July, we didn't have the last 3 months of your claims, so there's no way to really know. Unfortunately, you did have a pretty high claims quarter, your last quarter, so that didn't help you from the Humana. To offset for some of those expenditures, Allegiance did give you some additional incentives. One is just the overall expenditure for the ASO, which stands for Administrative Services. The overall savings in that cost, so line to line, we're anticipating $16,000 in annual savings. And then they also discounted the first 2 months of your administration fee by in total around $31,000. And then you physically received a rebate check from Allegiance. Your last one just came in, I want to say last week. So it was broken out into 2 checks, one for $10,000, the other one for $15,000, for a total of $25,000 to offset for some of those expenditures. This does give a net difference in the ASO of $176,000. But again, this is when you're looking at ASO, you don't look at necessarily the cost on the administration piece. You want to look at the big picture because that's such a small fraction of your overall cost. So if we go to the next slide, we'll get into that part. And that's going to be on the network discounts and then also just the overall administration of the plan. So the network discounts, when we took your overall claims for the prior year and matched them as if we were under the Cigna network instead of Humana's network, we're anticipating an overall network discount savings of anywhere from $887,000 to $1.1 million, almost 1.2. I like to give a 3% variance for that. So a pretty significant savings in just the network discounts. So when you subtract out what the cost is by making that move, which again is just a 1-year cost, because after this year you'll no longer have Humana runout expenditures. So it's just this first year of additional cost. We're still expecting a net savings on the medical side of anywhere from $700,000 on the low end to $1 million on the higher end. And when we get into our year-to-dates, you're going to see how these are tracking nicely. Let's get in the next page, which is the pharmacy. This is the big one. And I'd like to hit on a few things that I think have been mentioned in circles around employees. We haven't heard as much directly, but I know just from hearsay. There's been some misinformation here and there. But if you look at it, the overall expected net claim cost, and this means that after the discounts from the network, this is overall the net claim cost to Blount County. With Humana, with your claims for last year, we're looking at $5.4 million in pharmacy expenses. With the CVS Caremark network discounts and everything else, we're looking at $4.9 million. The rebates, this is the significant part. With Humana, they were anticipating $220,000 in rebates. And to backtrack on what a rebate is, because that's usually the first question, what is a rebate? A rebate is every time that you have a brand name drug that is dispensed, some of the manufacturers will actually provide a rebate back to the pharmacy benefit manager. This is just the way that pharmacy works. A lot of PBMs or pharmacy benefit managers will retain a good chunk, if not all of that rebate, and that pads some of their bottom line. What we were able to negotiate with CVS Caremark through an employer's health arrangement with their contract is that you all get basically all the rebates. So it significantly increases your rebates. We're anticipating for this year alone, and keep in mind they pay in arrears. So your first rebate check will come in June for the first quarter. We're anticipating that you'll get around $770,000. As a spoiler alert, we're looking like your first rebate check in June is going to be anywhere from $175,000 to $250,000. And from what I'm told, although they told me not to tell you all directly, but I'm told to expect on the higher end of that. So it's quite possible that you could be getting a check for $250,000 or close to that in June, which would exceed your entire year's expected rebates when you were with Humana. So in one follow sweep. So this has been a tremendous transition from Humana to Caremark. Some of the misinformation on there that we've heard and hearsay has been one that you only can see a Caremark or a CVS pharmacy. We have reports showing that Blount Discount is still, if you add up all of their locations, they're the #1 provider of pharmacy and on your plan. If you do it location by location, they end up being the #3 provider, #5, and #7, I believe. So that is, again, entirely not true. And you're not seeing any shift directly into Caremark or CVS. In fact, your #1 is going to be Walgreens. So that's one piece of misinformation that I've heard. The other is that you have to have a separate ID card. And in fact, if you look at your medical ID card, there's a CVS logo on it. That's actually your pharmacy ID card. And then others where we've heard some medicines were not covered. Whenever we've researched it, we've had complete resolution on all of the inquiries that we've had if they've actually come to us. The problem is we've had a lot of folks that would complain that a medicine isn't covered. One earlier in the year was an EpiPen episode where an EpiPen wasn't covered, or what they were told. We heard about it through the grapevine. The person didn't actually come to us. We researched it and found out that they have actually filed it under the Humana insurance. So of course it's not going to be covered because you can't file it under last year's insurance. Whenever they filed it under the Legion or the Caremark, it was covered. So that seems to be the commonplace with it, was more of your transitional hiccups of people still filing under the old insurance, and that continued to be a problem even amongst some other folks. So when it comes down to actual pharmacy expenditures or claims issues, I got the list. We track every issue that comes through our office, and I want to say that we were at, for the year, of total concerns of right around 20 to 30, and all of them were resolved very quickly. And usually it was just an issue either at pharmacy level or at the member level. Occasionally it was something that may have been loaded individually wrong, but we were able to get it fixed that day. So there's not widespread pandemonium on the pharmacy side like some might lead to believe. And the big thing that I would encourage anyone that hears anything is to have them contact my office or Jenny's office directly. That's the way we're going to get it resolved. So you can see a net expected savings of $962,000. When we get through this is actually going to be a much higher number. So as another spoiler alert. The next page is going to be on the stop loss coverage. The stop loss, this is also exciting. I think I want you to find this as we go through this, how everything was very strategic in nature and how it's all kind of coming together. If you recall, last year, your stop loss and your dental insurance renewed on July 1st. So if this was just like last year, right now we'd be scrambling to deal with an increase on your stop loss insurance because it's likely that you're not going to have just a rate hold every year. And we'd have to deal with that. Well, we negotiated last year in July to change the stop loss coverage from $250,000 to $300,000. That means that whenever the claim is incurred, if you have greater than $250,000 or greater than a $300,000 claim, the stop loss insurance picks up everything afterwards. So if you have a $2 million claim, Blount County is exposed to $300,000. Previously, it was $250,000. The initial increase whenever we first got the renewal, was going to be a $277,000 increase to Blount County for the premiums for a $250,000 limit. The $300,000 limit was going to be $59,000. We're able to negotiate that down, even though you only had one out of like 20 carriers that wanted to provide a bid. But we're still able to negotiate that down to $150,000 for the $250,000, but a decrease for the $300,000. And considering you only had 3 claims over the prior year, your break even was 4 claims. It made sense to go with the $300,000. It's a little bit of a roll of the dice. If you have more than 4 claims, you're net negative. But if you have fewer than 4 claims, you're good. So we're able to get it from a premium standpoint to where you have a slight reduction, and that was in July. The cool part is back in the fourth quarter of last year, we were able to negotiate with them to change your renewal date from July to January 1st without increasing your premiums. So you're going to essentially have an 18-month renewal with this without any premium increase. So that's really exciting. We're very proud of that and happy. Let's go on to the next page. The dental insurance is kind of the same tune. So you were going to originally get an increase in July of around 6%, I believe it was. And then we were able to negotiate a rate hold until the end of the year. At the end of the year, Blue Cross was going to hit you with another 5%, with a 5% increase, which was going to be a $16,000 increase across the board, which again may not seem like much. We were able to negotiate that down to $13,000. But when we looked at Delta Dental in the last minute, they came in, Blue Cross was not willing to negotiate on that, and part of their negotiations was really just that, hey, we'll give it to you for this 5% increase, I think is what it ended up being. And we promise we won't increase it by more than 5% the next year. So you knew you were going to probably get another 5% the following year. Well, Delta Dental came in and they gave you a reduction of $50,000 in premium, and they agreed that I believe you have a rate hold for this year on the Delta Dental. So you have a 2-year rate agreement with Delta, and then you have a rate cap of 5% for the 3rd year. So it's a really, really good deal. I don't know about you, Jody or Jenny, but Delta Dental, other than ID cards in the very beginning of some people not getting them in the first couple weeks, I haven't had any Delta Dental claim issues. And their network is much broader, and you typically aren't going to hear any issues out of Delta Dental. So that's so far been very successful. Next page. Life insurance, this is the one that you hope to not have to deal with much. You had a rate hold with Humana, but since we're moving everything from Humana, it made sense to shop that out. For the same life insurance plan, we're able to get premiums reduced by $100,000. So that's kind of a no-brainer with Dearborn. I haven't had any issues on that. Unfortunately, we've had to use it. But to my knowledge, it's worked out. So. On the Superior Vision, this is the one carrier out of everything that we did this past year, and I'll tell you it's a big job for these ladies here as well as for our office to make all those changes in such a short time, but Superior we're able to keep, and there's a rate hold, and we're going to negotiate with them in January, see what other things we can do with them. With Worksite, that's going to be your Colonial products. We moved them to Colonial. Premium is going to differ based on what product line and what employee you have, just because it's an individual product. After just the transitionary type of issues you're going to incur and just technology problems that you sometimes have when you try to merge 2 platforms, overall now I believe it's running fairly smoothly. We're not running into issues, and I think it's going to go fairly smooth. Our overall total estimated annual total savings, if you add all those up, is anywhere from $2.3 million to $2.6. If you recall, we needed to be in that $2 million range because we were running around a $2.5 million deficit last year. So you will see, since you all are on a fiscal year and this is on a calendar year, I mean, it's not going to work out dollar for dollar, but it will definitely, it helps you be on the right page for the fiscal year. All right, let's go to the next page. This is when we get to the fun part of talking about where you're actually at year to date. And I put together this chart, it's hard to see on the screen, but in your packet, where we put together all of the numbers for 2015 and we're comparing it to 2016. So I hope you can see it. I know it's a little small. You'll see January in 2015 on the medical with Humana, it shows $971,000. You'll see in 2016, it'll say Humana, that's going to be the run-out claims that Humana still has. That came out at 609. This is where it's a little difficult to compare apples to apples just yet, because for the first quarter of the year, you're still paying out on claims that were incurred last year under the old contract. So just now is when you're going to start seeing the claims really significantly start to be affected. It has already been affected, but you were still under the old contract in some months. So you still had some areas there of duplication. So with Humana, you're at 609, Allegiance 268. So for the total on the very right column, it's going to be 877,000 compared to January of last year of 970. The average is a rolling average. So January would be the same as January's month. February would be an average of the first 2 months, and then March would be the average of the first 3 months. The reason we don't have April on here is because the data isn't released until the 15th of the following month. So we just have that. So the next meeting will have April on here as well. So if you look at the total average, that's, I think, the best indicator. For 2016, the total average as of March is $1,044,000. In March of 2015 is 1.1 million. So you're averaging a little more than around $100,000 a month, which comes out to $1.2 million, which, if you remember what we're at projecting on the medical, that's right in line, even on the higher end of where our hopeful savings is going to be. If you scroll to the next page, this gets into the pharmacy. And keep in mind, this does not even include the rebates. So this is the exciting part. The pharmacy is doing very, very well. A big part of that is also because Caremark is administering the plan the way it should be. We found under Humana that it was not. And the main example I can give to you is what's called we call it a DAW penalty. And off the top of my head, I can't tell you what that acronym stands for. One of you all can. Dispense is written, that's right. It's mind blank right now. But what that means is that under the Humana plan, you all have mandatory generics is the way that your plan works. So what that means is if you have a brand name drug that has a generic equivalent available, the employee is supposed to get the generic equivalent. If the employee still gets the brand name drug, the way that was supposed to be processed is that you not only have the brand copay or the cost, but you also have the difference between the generic and the brand is how much that person should pay. So if the brand name drug is $200, even though you were capped at a $60 limit under your previous contract, that person would have to pay the difference of the generic and brand, and that would be outside of that $60 max. Humana was not administering it that way like they should have been. So when you're looking at this, Caremark is administering the plan the way it should. So utilization is tracking better, and we're actually finding that people are going to those generics that they should have been going to before. And they're going to over-the-counter drugs that they should have been utilizing instead of charging the county a $200 claim. And a great example, there was a prescription claim where they were going to have, I believe it was a $200 claim, and they called and said, hey, this was denied. Why is this denied? And the response is, well, there's an over-the-counter equivalent that has the same formulary to it. They went to it, and so far there's not been any issues since going to it. So we're finding that on a very consistent basis. So you look at it, same process. The advantage with this is it's real time. We do have April's numbers in here, but with pharmacy, you're not going to have any of that lag carryover from Humana. So as of January 1st, all claims are going to be Caremark, not Humana. As of April, our average is $341,000 per month versus in Humana is $430,000. So you're tracking around $90,000 a month in savings. Again, this is not including the rebates. If you add in the rebates, we're tracking close to $2 million in pharmacy savings. So this is significant. So total difference this year, we're on track for $971,000. Again, it's really the first quarter, a little bit more in the first quarter, so a lot can change, but we're looking really, really good so far on that. Next page. And a big thing, again, to keep in mind is it's not like we gutted your pharmacy program. So it's not, those aren't savings just because you just aren't covering prescriptions. This is a cumulative chart. It shows the pharmacy and the medical combined. Your average through March, since we don't have the medical for April, is 1.38 million compared to through March with the last year with Humana, it was 1.5 million. So again, we're on track to save $2.1 million over the course of the year between medical and pharmacy, and that's, again, just in the discounts. You add in the rebates, we're close to $3 million. And we were just told on the pharmacy side that they've renegotiated their contract. You all work through a coalition to get that really good contract. So it's not really direct to CVS, it's through Employers Health. And Employers Health just renegotiated with Caremark so that they're expecting even deeper discounts next year and a greater rebate. So your pharmacy should be on track next year to where hopefully it'll mitigate trend that is expected anytime you do rebates. The next part, unfortunately, I don't have too much news to give on the medical plan audit. It was performed by HMS. The draft review is completed. We're still waiting on a response from Humana. So the way this works, it's a very lengthy process. The initial review on the draft side is a little bit low on the number. It doesn't quite get us to where we need to be, but we still have around 100 outstanding claims that could potentially be in there. So I'm not at a point where I can share where we expect it. The biggest part about this, though, and I know this is kind of hard to see whenever you're not looking at a specific number, is this audit uncovered procedural issues that is going to save Blount County well into the over $100,000 mark. And to tell you what the biggest part, as I have on here, is on Medicare Part B. So what we discovered through this, early on in the process, we received a questionnaire of how do you coordinate with Medicare? Well, as you know, with retiree coverage, once someone turns 65, they're no longer allowed to be on the health plan. So I think it was understood, well, we're not really going to have Medicare type issues. Well, the way you do actually have Medicare issues, and the way that occurs is if you have someone that's on Medicare disability. And it's not just on Medicare disability. This is such a unique subset. It's Medicare disability of the retiree population. So if you have Medicare disability of the retiree population, but the person does not elect Part B, your plan should not be paying as if Part B, it should not be picking up as primary. Medicare Part B should have been primary. Also, where it hurts the retiree is, let me give you an example of if someone did not elect Part B, and only reason why someone would not elect Part B is because there's a monthly premium attached to it. So they feel like, well, I have health insurance through Blount County, so why would I take Part B? So they turn down Part B coverage. What they probably don't understand is that retiree health coverage is not considered credible coverage in the eyes of Medicare. This is not a Blount County rule, it's a Medicare rule. So as we know, there's lifetime penalties involved with not taking it when you're supposed to take it. So if you didn't take the coverage in 2010 when you were supposed to, and when they turn 65, they're probably thinking, well, I'll just pick up Part B when I turn 65 and I'm no longer eligible for the Blount County plan. Well, unfortunately, when they turn 65, they might have a surcharge penalty of Medicare of, it could be 50% because it's 10% for every year you don't elect it. So that's where some of these retirees are going to have trouble that are on the Medicare disability. And so the way that your health plan should have been paying out is it should have been paying even as if they did have Part B. So what that means is if the person was if the bill was $20,000, the person didn't have Part B, the person essentially would get a $20,000 bill, which is negative. No one would want to incur that sort of charge, but at least that would tell the person, hey, I need to be on Part B, and notify them so they're not going to have a lifetime charge. That's what this audit has uncovered, and unfortunately we do have, you have 7 total retirees that should be on Part B that are not. So we were able to, the open enrollment deadline was in January through April 1st. We're able to get 1 person enrolled in Part B. They'll be enrolled as of July 1st. The others will have to enroll next year during January to April, and they'll be covered at that point. But this will save over into the hundreds of thousands of dollars just by making that procedural change and getting people aware and covered and taken care of. So that is the positive from the HMS, even if we don't have recoverables of that great amount. Last part is on the plan recommendations. Okay. For 2017, we're getting close to the last part. So we're not going to get into a bunch of different nuances. I know last year was a very difficult year to get past all the changes that we needed to, and we're starting to see some of that paying dividends. So we don't necessarily want to recreate the wheel. It's working right now. So we're not recommending any changes between the two plan designs. We know the two plan designs are currently approved by the state unless the state all of a sudden enhances their benefits, which I don't anticipate that happening given the last conference call I sat on where the state is losing a lot of money. I'd say that these two will be fine to be covered by the state as well. So we're not recommending any changes to the actual medical plan itself. So we'll go to the next slide. What we are recommending is part of the pharmacy program that we've discovered is you have a classification of drugs called proton pump inhibitors, or PPIs. That's going to be like your Nexiums, Previcids of the world. Back in 2009, I believe, you can correct me if I'm wrong, Jody, but 2009, you all passed a resolution that these are only going to be covered on a pre-authorization basis if you have Barrett's esophagus or if you have stage 3 cancer. Then those will be covered, but otherwise they shouldn't be covered. Unfortunately, that's a very difficult program to administer from a carrier standpoint, and so it really wasn't being administered that way. And so you had a lot of people on these drugs that in 2009, they weren't over the counter like they are now. So Nexium's over the counter now. You're going to have a few others come over the counter over the next couple years. But Nexium, Prevacid, and Prilosec and omeprazole are all over the counter. Dexilant is not over the counter, but chemically speaking, it's virtually the same as what Prevacid is. But I will tell you that this population of folks are very, very passionate about this drug. So they will say if I'm on a Prevacid, that Prilosec will not work for me, or the generic version of Prevacid won't work for me, or Dexilant, and so forth. We have had some success of moving some people to the over-the-counter, but as of right now, CBIZ is essentially manning your pre-authorization program, and that's not necessarily something that we should be doing, but we are doing because the exorbitant cost that it would incur to the county if you all were to have CVS Caremark create a pre-authorization program for you. With all that being said, really we need to get to you either cover them or you don't for this program. With the people that we're able to get over to the over-the-counter drugs, which actually saves them money if they do it right, it's just not run through prescription. Your overall estimated expenditures for the entire year is going to be around $10,000. So I will tell you that out of any issue that we've had, this has been the most vocalized issue to HR or publicly or anything else. And it's just not that much in claims exposure to Blount County. You have, I want to say, around 15 people that this affects right now. So I would recommend actually just covering it for right now, and maybe readdressing it whenever Dexilant comes over the counter as well, and then potentially remove it. But I don't know that it's worth creating more of a public outcry within your employee base just for such a small expenditure. Any questions? I know that's a lot, but okay. So let's go to the next slide. The next is going to be what we discussed last year, and that's installing a tobacco policy. Everyone's favorite part. What we'd recommend is a communication campaign as soon as possible for the upcoming changes that it's going to be here. Installing tobacco and non-tobacco rates, including tobacco cessation drugs in your program. We're estimating, your vendor states that the estimated cost increase to any program for including these is 5 cents per member per month. Based on 4,000 members, that comes out to around $2,400 over the course of the year. I find that to be really low, so I'm going to say the range is really between $2,400 and $10,000. But if you look at some of the over-the-counter or some of the tobacco cessation drugs like Nicorette and some of the other gums and patches, you're looking at anywhere from $8 to $40 per usage. Chantix is an overall program that costs $220, and after that, there's a high success rate with it of quitting. The tobacco quit classes, Covenant Hospital, and I know that Blount Memorial should also offer them. Those range around $100 per participant. They do require at least 15 to have it in there. We'd still bid that out though, just to make sure you're getting the best deal. We're estimating the cost to be around $15,000 for that. And then also we had no tobacco. Policy is good unless you have a policy for what happens if you don't abide by it. So we're working with the HR and we'll have a recommendation. We've already shown a few recommendations on the policy of what occurs if that does happen, and we'll provide a recommendation to the HR committee before the July meeting for this. So I put together just some rough estimates on what a non-tobacco and tobacco rate could look like. We understand that you want to incentivize people who are not tobacco users and de-incentivize folks that are tobacco users. So what I put together was a monthly deduction for the non-tobacco is $5 less per month for the employees that are currently on it. And then for employee, spouse, and families, it's $10 less per month. Conversely, on the tobacco rates, it's $10 more for the employee, and it's $20 more for any of the dependents. Keep in mind that the negative is if you do have a spouse that smokes, you unfortunately are going to have the tobacco rate for that spouse. But if you're an employee only and your spouse smokes, but your spouse is not on the plan, you're going to have the non-tobacco rate for the employee. So let's go to the next page. The option 2 is just the same concept. It's $5 more on the employee, $5 less on the employee, $10 less on the dependents, and same on the tobacco rates, $10 more on the employee and $20 more on the dependents. So let's go to the next page. So let's look at the implications for that. So the implications, if you had 100% of the population say they're not going to use tobacco, this would be a net loss to the county of $159,000. That also means you have no tobacco users and everything's great. You can be a non-tobacco user if you enroll in a tobacco cessation program or agree to abide by the tobacco policies. And we'll get into that in a minute. What's neat, though, is if you look at, if you have 97.5% of your population, which equates to just 44 people saying they're tobacco users, it's only a $69,000 hit to the county. At 95%, though, you're basically net even. So if you have less than 100 people say they're a tobacco user, it would come out to a revenue of $20,000 that you can use towards your wellness programs. And then if you're at 90%, that's when you get significant of a $200,000 difference. Again, you can use that towards wellness programs or future savings. Next page. So discount parameters, again, that's going to be a tobacco, non-tobacco rate. To be a non-tobacco user, you would have to agree to become a non-tobacco. If you're a tobacco user but want to stop, you enroll in tobacco cessation course and you complete the course. If you don't complete the course, then this will lead to you having tobacco rates either retroactive back to the enrollment date or the month following non-completion of the course. Administratively speaking, it's much easier to do it the month after the not taking the course. In 2018, we're recommending that you do a biometric and tobacco discount. This would mean that the same as above, that you'd be a non-tobacco user, but also create an incentive for people to get their biometrics tested, which means that you have a nurse come and take your blood work and then sit down with you and talk to you about your health risks. So let's go into the next page. That gets into biometric screenings. We are recommending that you do a voluntary biometric screening just to get people used to the concept. This would be in the springtime, and this would also affect your rates in 2018, because the only way to know if people qualify for that 2018 discount is if they do it early enough before open enrollment. So we'd have a cutoff of the end of spring to do the biometric screening. If you have new employees come in, they would just have different periods throughout the year that they can go get their screening. Average cost for the screening is between $50 to $60 per person that gets it. It's generally completed with a finger prick, and at that point, the nurse will sit down with employees and go through all of the results of that finger prick, as well as the questionnaire, the height, weight, everything. The information that we gather from this, one, it's going to be completely void of any identifying information, so we at the county will not get anything saying that Joe Smith is a heart attack waiting to happen. But I'll tell you that previously we've done these, and we've had an instance where we had 3 people sent to the emergency room immediately because they're about to have a stroke, because their carotid artery was 75% blocked. Those things happen consistently, and especially with a company your size, it's quite possible that it could occur. So that in itself can save you claims that don't happen on a catastrophic level. But also what it does is it gets us the data on the people that just don't refuse to go to the doctor, don't get their physicals. And so right now, those are the people that we're scared of. Those are people we have no information about because they don't have health claims. So we don't know if they're about to hit. So that's where this really comes into play. It helps us get that information, and it helps them understand that they're a bad claim to occur. We would bid out the vendors, make sure you got the one that best fits your needs, and they can give a great aggregate report so we can see where your outliers are of how many people that are about to have a really bad claim. And again, this is completely confidential and given to the employee on an individual basis, but the county is completely non-identifiable. The other part would be on the wellness, and we'd recommend forming a wellness committee made up of the employees from various departments. We'd want to also complete a needs analysis on the wellness side, so figure out what employees would be willing to do, what they're not willing to do, and help them have some part of the engagement into the wellness development. We'd want to include disease management to your health plan. We didn't include that at the beginning part of this year because Allegiance doesn't have the data. So it'd take the first 6 months just to get the data, and you'd be paying for 6 months of usage that you wouldn't have any benefit out of. So what Disease Manage does is they take the claims that they have in their file, and they're able to tell, okay, we have a diabetic here who's not compliant because they're not taking their test strips. We need to reach out to them, and they do a physical reach out to them and make sure that they're being compliant with all their needs. You have a very heavy population of diabetes as well as rheumatoid arthritis or anything that's surrounding that. Your rheumatoid arthritis tends to be I think 3 of your top 5 prescriptions are tied to that. So if we can get disease management there to really try to manage that disease in high state, we can really drive down costs. Overall expected cost is $2.75 per employee per month, comes out to $57,000 over the course of the year. Your national medical trend sits at 7.8 to 8%. This is just overall medical trend, what we expect. That is not specific to you all because we don't have enough data to really dive into it. But since we are coming against the gun of you don't want to get into a situation where at the end of the next year you're all of a sudden tracking negative, whereas this year you're positive, I'd still recommend an overall trend increase of probably around 5%. If you include pharmacy, it's like 8.5%, but again, your pharmacy is running well. So I'd say if you allowed for 5% trend increase of just the overall allocation, then I think that would help that. Next page. So it's getting a timeline. So May, we're making our initial review of the recommendations. June, we'd like to review the funding of the changes. And July, we'd love to have HR committee approval if that's possible. I know that we're talking about some different structuring issues. August, we'd go to County Commission for approval, and this would allow for September for us to be prepared with the communications and Chronos build out. This is a very big task on the Chronos build out for Jenny and her team. So this would give enough time to do that for us to have open enrollment meetings in October and for them to run smooth, especially without a lot of changes. And for us to have a January renewal date, and again, we'd have no problem in having ID cards in an employee's hands if they needed it. Since we're not necessarily recommending any changes, it'd be the same ID cards as before. And then a 3-year timeline on the wellness, and then we're wrapping up. Implementation, so 2017, again, the implementation of the tobacco, non-tobacco. We'd get some data analytics of the results of the tobacco programs to be able to discuss in 2017 for review of changes in 2018. Biometric screening in the spring with the incentive to have lower payroll deductions in January of 2018. And then new employees would be hit on a quarterly basis to try to get them in so they could get the reduced amount in 2018. We want to review and analyze any of the employee wellness surveys and committee recommendations to build out and make changes to the wellness as it goes on. And then ongoing communications and review of options for 2018 incentives towards the end of the year. The next slide is going to be in 2018. 2018 and 19, we'd want to have greater incentives with the biometric screenings to include spouses. This is very common to gradually include spouses in since they tend to be a huge part of your claims. And then we'd want to go out to bid for a wellness vendor. The advantages of wellness vendors and Maryville City Schools, a lot of the other areas use a wellness vendor. It's a website that does tracking, it does competitive incentives. It has health coaching, so if you have someone that does need a health coach, they'll do a reach out and do telephonic health coaching. They have different incentives. The one that I just did today with my company, I can pick up a gift card to like restaurants or travel, or I could pick up a Fitbit, you know, if I complete certain activities and qualify with points. So it's a really cool. Sometimes you can even qualify for, I guess, one of those nice purses that people talk about, like I think the Michael Kors course I've heard about. I don't know. So any of that stuff you can qualify. They're nice programs. Yeah. And then and it really streamlines the process. If you do wear the Fitbits, and we can encourage Fitbit use, or some of the other wearable devices, it will integrate directly with the web portal. So those automatically would download to it, and then you'd be able to see for incentive uses. And we would also provide some of those as an incentive. And then in 2019, that's when we'd want to look at, does it make sense for you all to bring the on-site clinic on-site and do a feasibility study and see if there's any kind of savings that you could achieve from that. Questions, comments, concerns, recommendations?
Anybody?
All right.
Yeah.
Wow.
Thank you, Cole. I think this committee recognizes what Cole and his team have been able to do with us since our first conversation started well over a year ago, and to have come in and assess this program and where it was, and then to make those recommendations that we did and enacted to turn the program around. And then these recommendations going forward will even enhance, I think, the employee experience even more, and bring us a healthier workplace, which I think is what we all want in the end. So if you can go back, Jody, to the time frame, can you pull that up? Right there, yeah. So you can see, obviously, we've got some time to get all this done, but it's a lot of stuff. And so as we move forward, if you can take this presentation and spend some time with it to see what questions you have, or additions or deletions or whatever it is that we end up coming to an approval on. You can see June will be here in no time, and then we need to get an approval ready for commission in July to vote on in August. So it'll be here before we know it, and so please spend some time with that if you get a chance. Anything else on that part of the presentation? Cole, thank you. Okay, we'll move on to input on items. Well, before we do that, let's go back, because now we do have a quorum, correct? Mm-hmm. And we can go back, and if we could go to item D. At the time, we could not approve the minutes of January the 19th and April the 19th, but we can now. So if I could get a motion to approve those minutes if there are no changes, additions, or deletions. And a motion by Mr. Carver. And a second? Mr. Hedrick. Any discussion? All those in favor say aye. Aye. Any opposed? Passes. Thank you. Now we can drop. Any input, public input on items not on the agenda? Seeing none, without objection, we will adjourn.